All right. Well, good afternoon or good evening, everybody. Thank you so much for having me. And working with folks in support groups is one of my most favorite things to do. I work in the fast paced acute care areas, and it's nice to see people surviving strokes and living good lives after strokes or brain injuries. Um, and people can thrive afterwards. And I learn a lot from my time I spend with you guys. So I really do appreciate it. I was asked to come back, and again, I thank you for that. I wanted to do something a little different, and so this is a pretty short presentation that I have done before. I've done it with my support group down here, and I've used it with nurses. Seizures are something that scare people quite frequently, not just people in the community, but it scares nurses. It's a scary thing if you haven't uh, seen a stroke before. It can look quite frightening, and even if you have seen a stroke before, it just feels like something's really wrong, and you got to do something. So, what I would like to get out of this presentation, or what I would like you to get out of this presentation, is that for people with strokes or brain injuries, seizures are not uncommon. And I want people to understand how to keep yourself to a certain extent, or your partner or caregiver, or family member or friend, how they can help you if you happen to have a seizure or someone happens to have a seizure around you. So I'm going to start the presentation though, and I would not do my due diligence if I didn't do a little bit of stroke education while I'm at it. So there are different types of strokes. The definition of a stroke is basically anytime you have an area of your brain that doesn't get blood supply. So, what is a stroke? Now you can see my little laser pointer. When a clot, like the little red dot there, comes up and goes into this artery in your brain, if it stops right there and blocks, you can have a large ischemic stroke. That's an occlusion type stroke where blood supply can't get to this area of the brain. And that area of the brain starts to die. And then it becomes necrotic. It's completely dead tissue and we can't bring it back. This is a hemorrhagic stroke where the bleeding into the brain happens. And it can be bleeding into the brain tissue or around the brain. So bleeding into the brain tissue is called an intracerebral hemorrhage. Around the brain is called a subarachnoid hemorrhage. This is a picture of an ischemic stroke. You can see, similar to the picture where the blood vessel was coming up, it comes up right in here, and this is the area of a real CT scan of somebody that's had an ischemic stroke, and this part of the area of the brain is now dead. And like I mentioned, it can happen from a clot, which is called an embolic stroke, or it can happen from this plaque or a thrombus from all of the plaque that builds up from having high cholesterol. It builds up in your carotid arteries here, in your heart, on your coronary arteries, it builds up in your aorta. Once these plaques build up, they can crack, and then those plaques crack, and then little pieces of clot can build up on them, kind of like a scab, and then it can break off and go up into the brain and cause a stroke. A lot of strokes can be caused from problems in the heart, and if your heart doesn't pump the exact way it's supposed to, then you can get clots that will bounce up, and you can see it's an absolute straight shot up to the brain from the heart, where these clots can come if the heart's not beating correctly. And about 80% of ischemic strokes are cardiac related. A large amount are cardiac related. Now, these are the signs and symptoms of stroke. So if you look at B is for balance. So actually, I want you to start here. Look at B fast. I want you to remember B fast. Be fast is a simple way to remember signs and symptoms of stroke. So balance is sudden trouble walking or being dizzy or being off balance. Eyes can be all of a sudden a visual cut in one of your eyes or very blurred vision. Sudden vision changes in one or both eyes can be a stroke. You have a sudden facial droop or facial numbness on one side or the other, you could be having a stroke. And you don't need to have all of these symptoms. You just need to have one of these symptoms and it can still be a stroke. So here we have arms for the A in fast. Arms or legs can have sudden weakness or numbness, and it's usually on one side of the body. The speech can get very slurred, or the patient or the person who's having these stroke symptoms can sound like they don't know what they're talking about, like they're very confused and they're not making any sense, or their speech could be just so slurred it's not intelligible, not able to understand. So these are the signs, the signs of stroke, and if any of these happen, you have to remember the T for time. So time means that stroke is a medical emergency. It is really, really important that if you have any of these signs of stroke, you need to call 911 and you need to come to the hospital and tell us you're having signs of stroke so that we can whisk you in here as quickly as possible, call a code stroke, get my stroke team down there and do what we can to try to reverse your stroke. So basically here it says time is brain saved, so you gotta move quickly. And I use this in the hospital, and we call our rapid response nurse if someone has a stroke in the hospital. But for you guys, you should be calling 911. You should consider this a medical emergency. If you were having chest pain, you wouldn't hesitate to call 911 for chest pain. So you need to call 911 if you're having signs of stroke. Now, here's back to our point of why the new stuff today is strokes and seizures. So having a stroke is the most common cause of having seizures in an aging population. 10 to 22% of stroke survivors experience strokes after a seizure. And I can tell you that the caregivers or the wives or the husbands of the people that are having these strokes that have seizures are scared to death of them. And once they learned that they are not life-threatening, they've learned how to deal with them. And so now I had one family member tell me now they can travel because if he has a seizure, she just keeps him safe for the few minutes he has a seizure. He takes a nap afterwards, and then they go on about their business. So they were able to go on a cruise and able to travel into other different areas because now they're not really afraid of when he has a seizure, they know what to do. But seizures are very common in patients with people that have strokes and stroke survivors. So what is a seizure? So your brain has electrical firing in it. It's all kinds of tiny little wires that talk amongst themselves as well as with the rest of your body. When you have damage to your brain, it's like one of those wires can start misfiring. And the seizures can stay in that one little area and cause what we consider a focal seizure or a partial seizure. So it might be just right in this area here that controls this arm. And so if that's the only place where it's firing, then you may only have a seizure in this one arm. However, that most often will spread through the rest of the brain, and you will have gone from a partial or a small focal seizure to a much larger seizure that is affecting your whole brain. And I'll show you pictures and stroke videos of all the different types, or many of the different types of seizures. Now, epilepsy is a diagnosis for recurrent seizures caused by whatever reason. We're not sure why. In some people just have epilepsy and they're not sure. They were basically born with the fact that they're going to have seizures. And some people may have seizures after like a stroke, and then they'll consider that epilepsy, but it's again, it's caused by the stroke. So that some people, you know why it's happening, and some people with epilepsy, we don't know why it's happening. So in the brain, you have white matter and you have gray matter. So the white matter is 40% of the brain. That is the myelinated nerve fibers, and they carry the information. It allows communication to the gray matter areas and to other parts of the body. Gray matter is the part of the brain where the neuronal cells, bodies, dendrites, the neurons are. The thinking part of the neuron is in the gray matter. And the processing of all the information is conducted in that gray matter. So it's kind of the thinking part of the brain. And the other part, the white matter, is the transporting part. So seizures happen for multiple reasons. We discussed hemorrhagic or ischemic strokes. It can happen for epileptics that don't take their meds for no other reason. They don't know why they're having these strokes or why they have epilepsy. It can happen with head trauma, infection, any central nervous system infection that gets in your brain. It can be a brain tumor that causes a seizure, any kind of drug overdose, or somebody that withdraws on some medications can be at risk for seizure. Idiopathic means that we don't know why they're having a seizure, and that happens quite frequently, actually. And now we're going to discuss a little bit of the different types of seizures. And so I mentioned the focal or partial seizure, and there's a couple. That's the first one that we're going to talk about. And I mentioned, if you look, I put the A here, and over here we look at the A. This is a partial seizure in the it says in the temporal lobe. And so it's firing just in this area of the brain. It's just going in this little area of the brain. It's not going all over yet, just in this area of the brain. If you have a partial or focal seizure that has what we call secondary generalization, that's over here. So it starts in the small part, but remember what I said, it can spread to the rest of the brain, so it'll cross to the other side, it'll spread to the rest of the brain, and then it can cause full body seizures. And again, hopefully no more technical errors, and I'll be able to show you examples of these seizures. So these are the different types of generalized. These are the types that happen to the whole brain. And you can get tonic, which is like a, somebody just gets tone and they stay stiff. And then there's clonic, and that's kind of a relaxed state, but usually they go together. So you have tonic, clonic, where they get stiff and they relax, and stiff and relax. It's really hard for me to do it on video for you. I'll show you pictures. There's a myoclonic, which is almost like when you're just getting ready to fall asleep and you wake up like that. It's like myo mean, it just is like one seizure jump, if you will. And it's not a seizure when you're falling asleep and you do that, but that is a type of seizure that you can have. There's one called an absence seizure that I'll show you is very interesting, and atonic seizure are also called drop attacks, where somebody has a seizure and it's like they shut the lights off and the person just falls and then they wake back up. And then we have some partial, simple, or complex, and these are some more of the more difficult to describe types of seizures, or the less frequent seizures. Now here's a couple extra definitions. I'm sure somebody's heard of an aura before. Some people have an aura before they have their seizure. Some people will smell flowers. They might hear something. They might get a feeling of deja vu. Different ones. What else is on here? Get a funny sound or a funny taste. That's an aura. And some people learn from that to where if they get that aura, they can sit down in a chair or sit down on the floor quickly so that they don't fall when they know that they're going to have a seizure soon. The seizure dogs, there are dogs that can tell when you're going to have a seizure, and I don't know too much about this, but I'm thinking the dog is picking up on something with that aura with that patient. But there are certain seizure dogs can be trained to identify when you're about ready to have a seizure. Um, and I think the aura has something to do with it. The term ictal is your actual seizure activity, or during your seizure is called the ictal phase. And post-ictal is something we see a lot in the hospital after they're done with their seizure. We go take care of them. Their person is really, really tired, or they don't wake up completely. They're decreased level of consciousness for a while because they're just exhausted. That's the post-ictal phase, and they'll often sleep through that next hour or so. They're just tired. And then intra-ictal is the time in between seizures. But the most important part for your case is this aura. If you're a person that has seizures, you should pay attention to see if you have any signs of an aura, because it can help keep you safe. So partial or focal seizures, this is like the seizure I mentioned. The person has a little extra firing going on up in here that controls your right arm or your right hand, and you might be having a little seizure in your right hand. But this particular seizure is the only kind of seizure that the patient or the person having the seizure does not lose consciousness. So this is kind of rare because the person can really say, look, I'm having a seizure. They're aware enough that they're having a seizure. You may experience the aura with these types of seizures. And then the other thing with these types of seizures, these simple partial seizures, they can still spread and become a full complex partial seizure that spreads to the whole brain. Now, cross your fingers. I like the videos to work for us. The complex partial, this is another, this is a partial focal seizure. This is the next step up in types of seizures. So this guy looks like he's kind of awake. He will make what we call some automatisms, and he'll move his lips a little bit. And sometimes if you see, I don't know that we see his fingers, he might be like doing like little pill rolling or moving his lips. They're called automatisms. These seizures only last 60 to 90 seconds. The patient or the person is usually a little confused and very tired afterwards. They don't usually recall the episode. And again, these types of seizures can evolve into other types of seizures. Let's see if this will play for me. Oh, I'm so mad. Okay, I just have to breathe.
It's okay, Angie. I just wanted to say, if you would like, I can definitely send out the links to the videos. I can do on that, and we'll just give that to everybody.
Yeah, I'll have you send them out. I'm so sorry. This is very frustrating.
It's okay.
I know. Sometimes things just don't go well. Anyway, I'm going to finish my presentation for you without the videos.
Okay, thank you.
Okay. So next, there we go. So a secondary or generalized seizure, again, also this is still considered a focal seizure. It does begin with an aura, but these definitely evolve into complex seizures. So it starts out small, and then it gets larger quite quickly. Again, just an idea where if you start out over here with a small focal seizure, it can spread all across to the whole brain and become a primary generalized seizure. Here you can see the gray matter and the white matter of the brain. This is a nice picture of gray matter and the white matter inside. So this is a more generalized seizures. This is the type of seizures that happen in your brain all at the same time. So you don't start out with one arm and then it travels. You basically start out as a whole body seizure. And so this lady she has what they call tonic seizures. And so she just gets an increase in tone in her whole body. It lasts several seconds. And if this happens to someone, they will often fall because it's any type of seizure is not good to have standing up. You will often fall. But this one, the whole patient gets really, really, you can't, I'm seeing if you can see me, but gets really, really stiff. Everything's stiff. Legs go out, arms go out, whole body is stiff. She's not jerking, she's just stiff. And this particular person will be exhausted afterwards, and like I said, has the increased chance of falling. So other generalized seizures include a clonic seizure, and that's more of a rhythmic jerking type of movements. These patients do have loss of consciousness. They can involve both the upper and lower extremities, and these are most common in children. A lot of children have seizures. This is your big general tonic-clonic seizure. These are the kind of seizures you see most often, or when you think of a seizure, this is usually what you think of. And this woman starts out like she is right now, resting, and all of a sudden both arms start jerking, her head starts bobbing, her feet start jerking, she knocks her glasses off, and she's just got very rhythmic jerks. In the hospital, when somebody is moving their arm, or they're having rhythmic movements of some part of their body, one way we can tell if they're having a seizure is we can walk up and touch their arm, or touch their leg, and just be very gentle and just put your arm on there. And usually if it's not a seizure, it will stop. It will not stop if it's a seizure. No matter how gentle or how you touch somebody, a seizure is not going to stop. But if it's just some sort of other types of rhythmic movements, then it's not a seizure. And so that's something good to know when we're looking at our patients here. So myoclonic seizures, again, I mentioned they're like the shock-like you're falling asleep and you wake up real quick. They usually occur upon waking or falling asleep. Your consciousness is not impaired, but they're just very quick shock-like little seizures. This one's called an absence seizure, and I wish you could see all the videos, and hopefully I will share and you will be able to see them. But this little boy's walking around, and all of a sudden you see him kind of looking up in the air, and his head starts bouncing a little bit, and he's just looking up in the air, and then he just keeps on walking, and he walks. He has a little seizure, but he's just standing there for a second, has his little seizure, and then keeps walking. This type of seizure is sometimes found by teachers. They will think a kid is not paying attention, or the kid's missing everything in class. Kids can have hundreds of these seizures a day. They can have them, 6 or 7 times an hour. They can easily be missed if somebody's not paying close attention to this kid. And so when a teacher finds something like this, and we figure out that it's a seizure, and then it helps the kid, we can treat the seizures, and then obviously they can start learning and paying attention in school a little bit better. But you have to really pay attention to the kids to catch these. And this one is called an atonic seizure, or a drop attack. And again, I wish I could show you, but this gentleman right here, this kid, he walks around with his paper and talks to the kids, and he comes back over here and he just collapses. He actually hits his head on this table and falls on the floor. And no sooner does he hit the floor as he's waking up and standing up, rubbing his head. So one of the things that these kids do is they often will put these kids have helmets on them. And so that if they fall and hit their head, that they have a helmet on and they don't end up with a brain injury on top of whatever's causing their seizures to begin with. Then there's something called status epilepticus, and this is a medical emergency. This is dangerous, but this is a seizure that lasts more than 30 minutes. So if you have somebody, or you know somebody that has seizures, their seizures should be done within 2 to 3 minutes. They should slow the seizure down, or their seizures should slow down. Their breathing should get more regular, but they might get kind of diaphoretic. They might get a little blue because they're not breathing as well. But really, as long as it stops within 2 to 3 minutes and they start looking a little bit more normal, they're okay. If it lasts more than 3 minutes, then I recommend, if you are out wherever you are, to call 911, because it could be a problem and you would want to get them on their way. These patients, it's very exhausting for the brain and can be very damaging to the brain to have continuous seizures. And so we need to make sure that we get these under control as quickly as possible. And there are times in the hospital here, we'll have somebody in status that we will have a max on drugs and on a breathing machine, and we're trying to control their seizures, and it's really hard to get them out of their seizures. We may have to manage their blood pressure and their airway, and these can be very, very sick. And sometimes these patients can even die. This is the bad part of seizures, but that's only if they last longer than 3 minutes, and definitely if they get to 30 minutes, it's definitely status epilepticus. So seizure precautions. If you're in the hospital, we keep suction next to them, and we keep a tonsil tip catheter, basically a little, we can put it inside and suction any secretions. We keep oxygen next to them, and we keep the bed in low position so that they don't fall out of bed. If they do fall out of bed when they're having their seizure, it's low. We keep the side rails up with seizure pads on them, so if they're having a seizure, they don't hurt themselves. We'll get an order for medication up front so that we don't have to spend the time calling the physician, waiting for the physician to call back so we can get the medication order. So one of the things that's coming up in here is when to call the doctor. If you're, say, husband, wife, and the husband had a seizure, or the husband had a stroke, and he's 6 months out from his stroke, and you guys, the husband and wife, are at dinner. They went out to dinner. And if the husband has a seizure, and it's the very first time he's ever had a seizure, I would say you call 911 and get a workup to see what's going on, if he's never had a seizure before. If he has had seizures in the past, then there's no reason to call 911. If he's sitting at the table and he's having a seizure, you would try to put him on the floor. If there's meds that you have because you know he has seizures, then sorry, always getting doctor busy. If you would, the goal is to keep the person that's having the seizure safe. So you need to stay with the patient. If they're in a chair, try and ease them to the ground. Just lay them on their side, call it the recovery position, so that any secretions come out, they would go out their mouth and they wouldn't aspirate on them by sitting backwards and having all the secretions go down in their lungs. Don't restrain the patient. Like I said, when you hold them down, they don't stop. So if you're holding them down and they're continuing to have seizures, it could hurt them and you. So we don't want to restrain them. We just kind of keep them safe. Apply oxygen if you can. If you happen to have it here, we put some oxygen on them. We'll put a little face mask on them, try and keep them oxygenated. You could definitely remove their glasses. If they have any restrictive clothing on or something, you can just kind of loosen things up, again, to keep them safe and kind of keep them comfortable. And if you don't have suction and you're sitting at the restaurant, get a napkin and wipe the secretions away from the mouth, or any food that's in their mouth. Do not put your fingers in their mouth. That used to be something we did years and years ago because you didn't want them swallowing their tongue. We don't do that anymore because you can get your fingers bit. Um, when someone's having a seizure, they're often biting down and they might bite their tongue. So you might see some blood from their tongue, but you do not want to stick your fingers in there. Just remove the secretions and they'll quit biting their tongue when they're done having a seizure. I teach this to the nurses as well, but this is something that you, as somebody watching someone having a seizure, may want to consider. So pay attention to when it starts and how long it lasts. First of all, you want to know if it's going over those 3 minutes because you want to be able to call 911 if there's something up. You want to watch for them and make sure they didn't have an injury. Maybe he had the seizure, fell off the chair and hit his head. So now when 911 comes, you need to tell him he hit his head as well. But watch for injuries if they fall. If 911 gets there or paramedics get there, they're going to check their vital signs. With you, if you're with them, you could check their pulse and see it, make sure they have a pulse, but you don't need a blood pressure cuff in your pocket. Pay attention to what they're doing, monitor their movements, try to pay attention to where the seizure starts. Did it start in the right arm or the left arm, or did the whole body start at one time? Privacy is good because sometimes people can be incontinent of bowel and bladder during a seizure, and so I've talked to people that have seizures and they get very embarrassed after the seizure. So privacy is a good thing. And then again, if the seizure is prolonged, make sure to get a hold of a physician. And as your friend or your loved one is waking up after their stroke, you want to make sure that neurologically they're the same. Basically, make sure that they're still speaking clear. They don't have any new signs of stroke or any other kind of brain injury. So just make sure that the person that wakes up is the same person that had the seizure a few minutes ago. Just kind of make sure they're coming back to their baseline. Again, with status epilepticus, we have to secure their airway. We give them a whole plethora of medications, enough to make a horse stop having seizures. And sometimes they work and sometimes they don't. You guys should not be seeing status epilepticus unless you're in a hospital with somebody. This is a medical emergency. So again, when to call the physician if it's a new onset seizure, or say the person he has seizures once a month, but his seizures are always just his right arm. And now all of a sudden it's his whole body. If it's a different type of seizure, you want to call your physician. And then again, you definitely want to call 911 if it's a prolonged seizure, anything over 3 or 4 minutes. And then it's the same thing in the hospital. Basically, if we have problems with their airway or their breathing, if their blood pressure is not stable, or anytime the nurse is not comfortable, we call a rapid response so that they can get some extra help.